Hello, everyone, and welcome to the sixth COVID-19 UEG webinar. And this is the second one, in fact, on IBD with treatment, service and research, presented by Professor Charlie Lees from the University of Edinburgh. I'm Charlie Murray, I'm the chair of the UEG Education Committee, and I'd just like to welcome you to this webinar and also remind you that we have others coming. We have a further webinar on the 15th of July coming up, and that's by Heinz Hammer and Giovanni Barbara, and that's really looking to the future now that we're well into this COVID-19 period and what lies ahead for general gastroenterology services in future months and indeed years. So we'll be looking at more data tonight. Obviously, over the last few weeks, there's been an incredible amount of more information about COVID-19 and its effects on all services and indeed our health in general. Professor Lees has had a very close look at this and has updated all of the presentation that occurred initially, so there'll be a lot of new information to digest in this. Some general points for you. We'll be seeing Professor Lees' presentation in a minute. I'd ask that you can ask questions throughout that on the chat function, and I will pick them up after the talk is ended. And at that point, we should have a good period of time to answer some of those questions and have what I'm sure will be a really interesting discussion. If you do have problems with the technology or that it drops out at all, it's often worth refreshing your browser. You will see comments from our moderators from the office in the chat function as well, and can sometimes answer some of your questions. Welcome to all of you from around the world. Welcome to all of the work you've done in the COVID-19 period. And I look forward, as I'm sure you do, to Professor Lees' talk. So without further ado, I'll hand you over. Charlie.
Thanks, Charlie, and thanks to UEG for having me back to provide an update on where we're at with COVID and digestive health, and particularly looking at inflammatory bowel disease. It's been a very extraordinary period of time for all of us. All of us, I think, have had very different experiences from each other, but shared in this common goal of trying to look after our patients and look after ourselves. And as I will illustrate, there has been a vast amount of information that has come to light, particularly in the last 6 weeks or so since we did the first webinar looking at this. And I've tried to review as much of the literature as is feasible to do, certainly all of the relevant literature, and to bring together some key learnings that we can take away for our practice and for our patients, and hopefully provide a degree of reassurance as we move forwards into the next phases of this pandemic. Here are the disclosures for both Charlie and myself. So here's a brief overview of the topics that we're going to cover. We're going to do a brief update on SARS-CoV-2 and COVID-19, a brief recap and a brief snapshot of what is happening at key pointers around the world, accepting that there are still very different trajectories of this pandemic ongoing. And it's very interesting to look on the chat function and see where people are joining from tonight. And you can have a look there yourself. People really are from all across the world. And I'll provide some insights as to what's been happening in some of these countries. And then we're going to look at what we've learned from the data that has been presented so far. We're going to look at risk generally for COVID-19 and bad outcomes. But then we're going to dial in specifically about IBD. Is there a risk for IBD patients? What about the risk of therapy? What about using our therapies? And then we're going to finish by looking at some innovations, collateral damage, and a couple of forward pointers for us all. And so I said that there's been a lot of information, and boy, that's true. If you look on PubMed, on the newly refurbished PubMed, you can see now, just for a simple search for COVID-19, which of course was 0 prior to January this year, there are 20,800 results, and it's going up rapidly. But what's fascinating here, and what you'll see throughout this presentation, is that a lot of the data is still in its preprint format. And so here, what we're challenged as a community to deal with is preprint data that has not been through formal peer review, most of which is on medRxiv, some of which is also on bioRxiv. And quite ironically, this chart here, which is all about the preprints from COVID-19, is itself a preprint on bioRxiv. And this timeline here shows you in the top panel the cases in the pink and the deaths in the green from COVID. So you can orientate yourself here to the start of January 2020 at the left-hand side of the x-axis. And then you can see here the publications, those that are in the journals, and now on PubMed in pink, and in the green, those that are preprints. And so this does leave us some challenge about how we interpret this data. And so I urge you to take, with a degree of caution, what I'm presenting here today, and perhaps go to some of the source literature yourself to look and wait to see these papers come out in full. But I have reviewed all these data, and for the most part, I'm confident that they are at least providing a robust message, and we can then provide interpretation on that. Okay, so in a nutshell, what do we currently know about SARS-CoV-2, the virus, and COVID-19, the disease that it causes, and what do we know about it in the gut specifically? We still know, and this is very important to remember, that the virus enters via the nose, mouth, or eyes and attaches to cells in the airway that have the ACE2 receptor. We also need to bear in mind this co-receptor for the virus, TMPRSS2. Both of these receptors are found on the cells of multiple organs, including the gastrointestinal tract, ACE2 rather more in the small bowel than the colon, and the co-receptor in the converse. The levels appear roughly similar in IBD patients and controls, but they may be decreased by medical therapies, although we don't, I think, yet have a definitive study on that. We have seen, importantly, that IL-6 and TNF can upregulate the ACE2 receptor expression, as does infection with SARS-CoV-2. We know the virus is found in stool even after respiratory clearance, and there is a big data set around this now, which I'm not particularly going to review because I think we still don't quite know the answer as to what the relevance of that is for gut symptoms. But we do now know that there is a group of patients who will present with predominantly gastrointestinal symptoms as their primary presentation of COVID, and that may be in the range of about 10%, but gastrointestinal symptoms may be present in a significant other proportion of patients with COVID. And there is some data that supports that those people that present with gastrointestinal symptoms have rather worse outcomes. And one data set shows that patients presenting with COVID-19 have raised fecal calprotectin noted. The issue about transmission, the issue about PPE is, of course, really vital to us in the hospitals, as well as particularly endoscopy for the surgeons in the operating theatre, and, of course, for society as a whole. And there has been some debate on this. This is a recent meta-analysis from The Lancet, which I think has influenced global thinking from the WHO, as well as, particularly in the United Kingdom, and I'm sure in other places, about the use of face masks. It shows clearly that physical distancing is important. So on the top right here, you can see the difference with and without 1 meter or more of distancing. In the middle panel, you can see the advantage of wearing face masks. And also the bottom panel, the advantage of eye protection. And I think it's an important thing to consider. And it's all about exposure of the amount of virus to patients or to the general public. So I think this is something that's continuing to be shaping policy. This week, some of you may have seen a rather misleading post via the WHO, which has subsequently been clarified about asymptomatic transmission of COVID-19. And there is some debate still about this, and there are some definitional problems with asymptomatic versus pre-symptomatic. But this table from Annals of Internal Medicine, I think, very neatly summarizes the cohorts where we can look to see what the asymptomatic transmission rates are. So these are patients who are positive but asymptomatic, and you can see it's roughly about 40%. So I think it's fair to say, and this is quite a high level from other viruses, that about 40% of SARS-CoV-2 patients are asymptomatic. And this is, of course, important when it comes to thinking about isolation and hibernation for contacts, etc. So we've attempted tonight to update the timeline of events that's been happening with COVID. And it's been a very interesting task because a vast amount has happened. I just think it's important to remind ourselves that this is only a situation we've been dealing with since January. 24th of January doesn't actually feel like that long ago when you put it on a calendar, but that's when Wuhan went into lockdown. In the UK, we began our shutdown on the 21st of March. You can look at April and you suddenly see all these other timeline events happening, including for us, this very sort of dramatic event where our Prime Minister in the UK ends up in intensive care, but many other key events with the cases ramping up very, very quickly indeed. So already here by the 27th of April, you see 3 million cases. By the 28th of April, 1 million cases in the US. And these very profound effects that have been seen across, and many unintended or perhaps unexpected effects too. For example, here the WHO and the World Food Programme putting out this stark message that hundreds of millions of children missing out on school meals and potentially in danger of food poverty as a result of all of that. Let's just have a look and just orientate ourselves as to what's been happening throughout the world. And I spent some time putting together a selection of countries' profiles that allows us to look at the different trajectories and allows us perhaps to discuss on some of the measures that have happened and perhaps allows us to reflect on different experiences that we have had across the piece. So this is the rolling 7-day average of daily confirmed cases of COVID-19 with the US, of course, this massive outlier at the top. The United Kingdom, unfortunately, also a very significant outlier, with France and Italy and Spain prior to that. This is all standardized days since confirmation of the first time reached 30 per day. So that's why it all looks relatively stabilized. You can already start to see some of the success stories, Scandinavian countries, Iceland in particular, very clearly noted here. Other success stories, including Greece, isolated down here at the bottom. Sweden, a very interesting story here because Sweden took a different tack with Scandinavian neighbors, and that's something that can maybe be discussed. But elsewhere in the world, and this is a truly global audience tonight, we are very conscious that the trajectory is different around the place. And I think this is important for us to bear in mind as we have this conversation. Brazil, India, Pakistan, Mexico, Saudi Arabia, which is interesting because they relaxed their lockdown for Ramadan, and you can see perhaps this shift afterwards. Iran, which had a very big initial burst and relaxed its measures, perhaps seeing one of the first clear evidence of an early second wave, although there is some debate around testing, etc. And then some very positive examples. We've seen New Zealand this week declared virus-free and all measures released, Australia and Iceland on that map too. And a couple of other interesting examples in the middle here, where countries have looked to draw on their early successes. South Korea with a very tech-savvy test and trace program. Japan with a rather more pragmatic approach, trying to avoid congregations of people, etc., and the different success stories that are noted on there. One of the rather sort of black advantages of in the UK having such a disastrous COVID, as I think it would be fair to say we've had, means that we can have a large amount of data to supply to this effort. And one of this preprint cohorts that I want to just come to here is this open safely data, which we should see in full publication soon. This has come out of the Data Lab in Oxford and is a very large collaboration, and I think is a very keen example of what can be done with technology and big data. Here, what they did was that they used this program called Open Safely to go inside the GP electronic registry, so they didn't have to extract any of the data, to then perform the analysis on what was at this stage 17 million adults across the United Kingdom, of whom they had unfortunately about 6,000 linked COVID-19 deaths. And it allowed them to perform an extremely detailed analysis, confirming what we knew about age on the left and sex, so that older men in particular at very marked increased risk. And then on the right, what you can see, and I'll just walk you through this because I think it brings out some very pertinent points as we all move forward. You can look at age here. You can see the reference line for each of the examples is the red line. You can see the increasing groups of age going out to the right. I'll just change my pointer here. There, that's better. You can see sex, male sex compared to female sex, and then you can see increasing classes of obesity. You see, interestingly, there doesn't seem to be an increased risk with current smokers, which is fascinating, but slightly increased risk with ex-smokers. We see this very troubling increased risk with non-white ethnicity, which does not fully correct for comorbidities. We also see this troubling increased risk with social deprivation. So big challenges for us as a society to try and deal with these issues. And then in terms of comorbidity, diabetes is a big risk, cancer is a risk, previous hematological malignancy and respiratory disease. It doesn't, unfortunately, yet answer the questions about inflammatory bowel disease. This is the Scottish data that's also just come out in preprint that shows some increasing highlights. It shows in particular here the very low risk of severe and fatal COVID-19 in young people, which I think has been one of the blessings in part of all this process, although, of course, that risk is not completely absent. Interestingly, in the Scottish cohort, there was not observed this association with non-white ethnicity. I think this is a very important thing for us to talk about, and we shouldn't escape from doing it. This is a very nice systematic review and meta-analysis from eClinical Medicine. The references are all here at the bottom. The slides will all be shared afterwards, and the webinar will be recorded if you want to go back to any of these in particular. And this looks at US and UK different ethnic groupings, looking at the risk of infection with SARS-CoV-2, the risk of hospitalization and ITU, and the risk of mortality, and showing, unfortunately, this increased risk in non-white ethnicity in many of these areas indeed. So this is something that I think we need to think about globally as a society. I think it's a very important thing not to escape. Okay. The reason for going into all of this is because what I'm now going to show you is a reassuring message about inflammatory bowel disease as a risk in itself, and also mostly about IBD medicines. And so when we consider our very large IBD populations, bear in mind that in many parts of the world, we're dealing with nearly 1% prevalence. Many of our patients are older, many of them are of non-white ethnicity, many of them have significant comorbidity and other risk factors. And I think those risk factors predominate when it comes to stratification. So let's review the evidence. Are our patients at increased risk? Where is their biggest risk? What about their medicines? What about other risk factors? And we'll come to collateral damage afterwards. Now, this is the published data. With one addition, the Italian data set, which I'll come to in a minute. And what's very striking, if you look at these data that are actually published in full from APT, Gastroenterology, IBD, the numbers of IBD patients who are positive and or hospitalized are very small. 12, 15, 80, 4 from Greece here. And so we need to look at bigger data sets and bigger endeavors to try and get at the risk. We don't yet see anything that particularly tells us that IBD patients themselves are at risk of getting COVID-19, which is reassuring. There are a lot of therapy considerations to take into place, and we've talked about these before. The big conversation I think we have had throughout is about the balancing the risk of immune-modifying drugs with the risk associated with active disease. And this has been to do with not avoiding treatment. It's been about trying to maintain therapy so that we don't get patients hospitalized, so we don't get patients needing steroids or operations at a time when COVID is still a problem in hospitals, when patients are afraid of being hospitalized, and from a surgical perspective, when COVID is still putting in place a bit of a blocker for what we're doing. So these therapy considerations, I think, are still very relevant. So let's review where we have got to date with all of this. Now, last time when we had the webinar, this IOIBD, International Organization of IBD RAND panel, this consensus grouping had just been published and we reviewed it then. I'm putting it back up here again now because I don't think anything substantial has changed in terms of what we now know, and it remains the biggest international consensus from IBD experts about the risks of therapies, suggesting that mesalazines and budesonide didn't present a risk, that prednisolone did present a risk, that Vido and ustekinumab did not present a risk, and that the other drugs, there was some degree of uncertainty in the piece. And perhaps we can provide some additional reassurance from that. Based on that evidence and the literature that we had at the time, which was mostly based on non-COVID infection risks, we in the UK and others have followed similar process of looking at some kind of risk stratification for our patients. And I think it's worth just putting this back up. We've reviewed this as a grouping in the last couple of weeks, and we think this is still relatively true, that the biggest risk is from older patients with comorbidity, top left. And where it's an IBD-specific risk, it's steroids and it's people with active disease. And actually, those in the moderate and the lowest risk groupings perhaps are not at significantly increased risk compared to the background population. The secure IBD registry you will be aware of, I hope by now. This is the International Organization of IBD initiated project that is being led out of New York by Ryan Ungaru and in Chapel Hill, North Carolina, by Michael Kappelman there. And it also has been inputted by substantial numbers of people from around the world. So this is for people who have confirmed COVID-19, reported after a minimum of 7 days, and sufficient time to observe the disease course through to resolution of acute illness or death. It's a slightly tricky data set to report right now. On last looking, there are 1,450 patients who have been inputted into the database, but the primary data set that is reported in gastroenterology last month is of 550 patients, but there are some important learnings in there. Anti-TNF therapy, ustekinumab, vedolizumab, and tofacitinib do not appear to confer an increased risk. Steroids do appear to confer an increased risk. Some of you will have seen what appears to be a spurious association with mesalazines, and we all believe that it is just that, associated with older patients and the other confounders that are inherent therein. There is an Italian group that have reported about 80 patients in gut about 2 or 3 weeks ago now. And this is pertinent because this shows some of the things that we know about, including age, of course. But this very neatly, I think, brings out the risk of active inflammatory bowel disease and of corticosteroids. So the IBD literature to date, I think, paints a reassuring picture. And we can also learn from our rheumatology colleagues. The rheumatologists, as a global alliance, have looked at the risk groupings. They have looked at the risks of DMARD therapy and the risk of steroids. And I'll just highlight both of those at the bottom here. So in the green boxing here, you can see the risk of those patients on DMARDs and those in combination therapy. And in fact, quite surprisingly perhaps, but very reassuringly, there is a protective effect of COVID-19 disease for hospitalized patients with DMARDs and combination therapy. So that is very reassuring and consistent with what we were seeing before this increased risk of steroids. So put all these things together, what do we see? We don't see an increased risk with IBD overall, although that data is still slightly patchy. We do see an increased risk of prednisolone, but we should still, I think, judiciously use steroids where we need to make an impact to someone who's got severe disease. And we do see a reassuring message that anti-TNF therapy, ustekinumab, vedolizumab, tofacitinib don't present an increased risk. So how do we then adapt this data to provide guidance on what we do if we have a sick patient in front of us? And as IBD physicians, there's nothing sicker than the acute colitic that presents to hospital. There is now in gut an updated RAND consensus statement that looks specifically at this question. This rather complicated flowchart on the right, I won't go through in any great detail, but I would urge you to look at this actually if you're having any of these questions about a new colitic patient, because it will help you guide through what we believe is different in patients who are now admitted in the COVID era with acute colitis versus what you would have done ordinarily. And I think the key points here is that if you have a sick patient in front of you, you need to continue to treat that sick patient as you would before. So we encourage patients to still have intravenous steroids, to still have the appropriate investigations, to still have rescue therapy according to what you would have done before, but to test appropriately, to discuss with a COVID-19 specialist the key time points, to continue to involve surgeons early, etc. So I think this very neatly covers many of those different uncertainties that we will all continue to have about managing the sick patient in front of us. We have to, I think, manage the disease that's in front of us and not let our patients get sick through fear of the ramifications of COVID. We have to do the best that we possibly can, and there is now guidance there for that. Okay, I'm just going to change gears slightly because despite all of the adjustments that we've had to make very rapidly across the world with our service, what is very gratifying to see is a great deal of collaboration and innovation shining through in spades. And I'm just going to pick out 2 points where I feel I can talk to this from personal experience. There are many other examples here. So please forgive me for not covering those that you might know locally in more details, or those things that you've been involved with yourselves. From our practice across the UK, and very specifically in Edinburgh, actually, we've been looking at how we would maintain our team, how we would virtualize working, how we would deal with a suspension endoscopy, and how we would deal with our infusion suites. But one of the things that we did right at the very start, in fact, the very first of our flare clinics was on March the 18th, I realized the other day, right early on. And we did this through a couple of very simple interventions. We set up a virtual working pattern for our IBD core huddle, which congregated at 10 a.m. every day, Monday to Friday, without fail, with a consultant covering, usually 2 of us, usually 2 IBD nurses, one of which was always working from home, with our IBD pharmacist and with our dietitian if we needed to. And from that, we fed into our flare clinic, which we ran every day at lunchtime, with seeing 2 to 4 patients with a core group, with PPA, with special guidance so that patients have minimal footfall through the hospital. And we used minimum steroids, but steroids where we needed to. We used early biologics with all the counseling and the screening done, lots of enteral nutrition, close monitoring, Calpro at home, etc., with priority access to the infusion suite. And I'm confident that having done this, what we've done is we've seen the patients we needed to see, and we've averted up to 50% of admissions from patients who would otherwise have just fallen through the gaps. Things would have been left too long, and that would have been sadly inevitable. Another area where we have all had to change is with how we deal with our outpatient clinics. It's not been possible to run face-to-face clinics. So we've had to move to some kind of virtualization, be it picking up the telephone or be moving to video consultations. And this is something that we're all still grappling with, I think. None of us that I'm aware of have moved back to full face-to-face provision. And so we have to, I think, look at this in some detail. So I'm just going to talk to this for the next 5 minutes before I wrap up. I was very interested in this aspect because I was very clear speaking to people locally and nationally and friends across Europe and the US that practice was very different. So we did this very quick collaborative survey using Google Forms and then using the power of Twitter and social media. And I'm very grateful many of you on the webinar tonight will have contributed to this. So thank you to that. We had 800 respondents from 56 countries. You'll see listed here the numbers. And the key results here, we're looking at the consultation methods prior to, during COVID, and the intention after COVID. And what you can see here is that most people, of course, were using predominantly face-to-face, and it dropped off rapidly during, and that after COVID, it's not going to go back to the same. And if we look at a global map, we see that in Europe, all of us are largely having to just simply pick up the phone with some, well, I've lost the slides actually. I don't know if they can come back. Moderator, brilliant, thank you. With some video compared to in the US, where there has been a very rapid wholesale switch to video consultation. So there are some learnings that we can share from all of that. Sadly, this picture here, which I found on Unsplash and the internet, rather fills me with fear about what our clinics will continue to look at like in the future, because certainly we can't go back to packed waiting rooms for our oversubscribed IBD service. So we have to think quite carefully about how we open up, what kind of provision, what kind of hybrid between face-to-face, phone and video, and how we deal with that with our patient groupings. And as part of that process, there are, I think, a few things to think about. The telemedicine setup, the pre-visit preparation, what you do during the visit, how do you address technology challenge afterwards, and documentation. So this, I think, applies to phone, but it applies very, very much to video consultation that many of you will be trying to deal with now. This is taken from a paper that will come out in JCC shortly with much more detail about how to do this. But I think from my experience early on and from others, the key is in preparation, having a reliable platform. We're very lucky in the NHS to have a very good system called Attend Anywhere that the NHS provides. But you need to select the right patients, or patients need to select themselves. It's not appropriate for everyone. And then developing a workflow about how to deal with these clinics, how to document, how to write consent, how to troubleshoot, how to document afterwards, I think is all important for us to consider. So with all of this COVID mess, the situation we've had to deal with the time that has gone on, I think for most of us now, we are dealing much more with medium and longer term impact, although it's very clear that around the world, there is still a significant number of our colleagues still dealing with this short term, and we can inform and educate all of us through what we have learned. And pertinently, I think here we have the issues about delayed treatment, delayed investigations, and postponed and delayed surgical interventions that are all going to be very, very present in our minds as we pick back up the workload over time. And the very real issues about stress, fatigue, and burnout that affect all of us. So how do we deal with all this moving forwards? And do we do this with any degree of optimism? Well, I think I'd like to start to conclude with a degree of optimism, because there are many, many different vaccines in development, with a lot of hope that at least one of them will be providing a clear exit path for all of us. Interestingly, there is a worldwide shortage of glass vials. And so I think as a worldwide community, we have to think not just about producing enough vaccine, but about producing and delivering the billions of doses of vaccine that need to go to everyone on this planet to provide immunization to our global human community. And perhaps more specifically, we need to think about the dedicated area of what we do with our IBD patients, who we hope we'll be able to vaccinate as a priority. And this is something that we are planning to study along with others about how this will be relevant for the IBD population as a whole. So we'll come back with more details about that. And then this issue about surveillance, which of course is different in different countries. I think it's a very pertinent thing for us to think about. I've just picked a couple of things here that I think are both interesting and relevant to us as gastroenterologists. And perhaps the one that we can look at with a smile on our faces is looking for future hotspots from sewage. And this is something that's received a lot of media attention, but actually a lot of study too. So perhaps the fact that the SARS-CoV-2 is present in stool, it has the downside for us as gastroenterologists in that it's one of the main reasons why we're having to wear full PPE and endoscopy, and it's slowing us down. But perhaps it will allow us to detect future peaks in community and regional levels by looking in sewage. There is a study here, a preprint here, that shows the correlation between sewage levels of SARS-CoV-2 and COVID positivity and admissions over time. So an interesting thing for us as gastroenterologists there. And then something that's close to my interests in terms of digital health is this very large US study looking at using wearables to pick up passive physiologic measurements such as tachycardia and reduced step count to pick up, again, regional and community level peaks of COVID-19 across the piece. So I'm just going to summarize here with, I think, one of my favorite quotes from one of the Stoic philosophers, Seneca, and a few points that are very similar to what I said before, but actually are definitely worth reiterating. It is a very challenging period of time. It has been a very challenging period of time, and for many people, it will continue to affect people in different ways. As people come out of lockdown, I think it is very important that we consider that everyone will have had a different experience of the last 3 or 4 months, be they our patients who look to be in similar situations as each other, be they our colleagues and our family and friends, many of whom superficially will look like they've been in similar situations, but many will have had very, very different experiences, and that will leave scars deep in some that we need to be very mindful of. And so kindness is my key watchword there. We need to meet the challenge of what comes next, to keep up to date with guidance and to communicate very, very closely. There is a lot of information out there. There is a lot of misinformation out there. And I hope tonight I've managed to clarify at least some of the uncertainties there. Importantly, I believe there remains no signal of particular harm with IBD itself or the medications that we use, with the exception of corticosteroids that we should be very mindful of, but we should continue to treat the sick patient in front of us to the best of our ability. Research remains our exit strategy. I think there are reasons to be optimistic, but we need to remain very, very focused to ensure that we don't end up with future big peaks of COVID-19 and that we, I think, more optimistically can ensure that the innovation that we're seeing right now persists in a post-COVID-19 world so that we can make things better for IBD patients and for all of us moving forwards. I'll hand back to you, Charlie.
Thank you very much, Charlie. That was a very, very nice way to finish. So be no surprise from all of our participants for you to hear that we are getting lots of questions in. I'm going to kick off with a general one, which actually hasn't been asked, but I think you mentioned within it, but it's been really relevant to me, certainly even today in clinical practice, which is how do we try and get our patients to get over this fear of re-engaging with services? You got any tips for that, Charlie?
Yeah. So, I mean, that picks up very neatly on what I was talking about, collateral damage.
Yeah.
And about how different people will have experienced lockdown in particular. We, as you will, as many, many others have, experienced this surge in calls to the helplines, to the IBD nurses, to the charity groups, to all the rest of it, from worried patients that have that map out to the different events that have happened and the different guidance that's been produced about what people should do and what communities should do in lockdown and all the rest of it. The thing that worries me most, actually, is the people that we haven't heard from. The people who have stayed at home, who've been afraid, the people who have decided that they must soldier on, or because they're too afraid to contact us, because they're afraid they might be told to come to the hospital, they're afraid that the hospital is a dangerous place. And that persists, that fear, even now when, for many of us in the UK, the hospitals have relatively little COVID in, and the hospitals are, I think, probably a relatively safe go on. Just finish that, because I think the thing that's really important is it's highlighted is that we don't really know how to contact all our patients at the moment. And for the future, if we could find a way to reach out to all of our patients at once, that would make a big difference. But yes, it's important.
And do you get a feel for, there's a question coming in from outside, in terms of the degree of anxiety and depression that in IBD patients in particular, do you think that is going to be easily reflected in the amount of disease we see at the back end of this pandemic?
Yeah, I don't think it's going to be easy to see, because I don't think we've been very good at checking for anxiety and depression in our patients pre-COVID. We know that when we study it formally, it's high. And I think we all expect it's going to be much higher afterwards. And so my suggestion is that we just monitor very carefully post COVID.
Okay, so I've got a more, if you like, a medical question, but very relevant to IBD management. So we've all seen a lot of thrombosis in our COVID patients, certainly part of the disease, part of the vascular part of the disease. In IBD patients particularly, is it your practice in COVID-infected patients to either prophylactically or in those that you don't have obvious thrombosis in, or those that you do, to give them anticoagulants?
Yeah, it's a really good question. And I'm not sure we have a consensus on that. For hospitalized patients, absolutely. Hospitalized patients should always get thromboprophylaxis with low molecular weight heparin, and that's more important than ever. What about ambulatory patients in the community who are COVID positive? There isn't a clear consensus on that, Charlie, but I think one should be mindful of that. And I think if one does have a positive COVID patient, it wouldn't be unreasonable to consider. I don't know if you have any particular thoughts on that yourself, actually.
No, I don't. I think the thoughts are very polarized. And in the middle of the peak of the COVID-19, there were lots of discordant voices, even in the COVID-infected inpatient population, as to what we should be doing. But I think at that stage, we hadn't really seen just how much thrombosis was going to be around in these patients. So I don't think those in the community affected that are ambulant, I would necessarily advocate anticoagulating, but certainly the inpatient population, we are. And we always have done for IBD patients prophylactically, obviously. Now, another clinical question. You've covered this in both webinars to a certain extent, but do you think now that we're in certainly in our part of the world, things are slightly quieter, and in other parts of the world, clearly there's a lot of COVID-19 still around. Do you think we should be postponing colonoscopic examinations on our IBD patients if they are deteriorating?
I actually don't. I think what we should be fighting for is for our IBD patients to getting scoped. And I think the big challenge that we have now as gastroenterologists looking after IBD patients is the massive backlog of urgent cancer diagnostic work that's going on in endoscopy. And I think the real challenge for us is going to be, how do we get our patients who need scoping for IBD into that backlog when most endoscopy units are not running at full capacity. So with the caveats that I think, do what you can with other monitoring mechanisms, using calprotectin, etc. But no, I think we should be scoping our patients when we need to.
Okay, so we've had unsurprisingly, we've had a few questions about the RAND panel and looking at what we consider to be safe or not safe in the treatment of IBD during this period. One interesting question, which I just lost because it's gone up on the chat function, is to you directly, Charlie. Is there any idea why combo therapy, for example, azathioprine and infliximab, does not increase the risk of SARS-CoV-2, while it can increase the risk of opportunistic viral infections?
I think the very honest answer is we don't yet have a big enough population-based data set to enable us to answer that question. And it's interesting just how few IBD patients across the world seem to have got COVID, which is reassuring. And it may be due to lockdown and shielding effects in different parts of the world that have helped to preserve that. But I think if you look across the piece, there does not appear to be an increased risk with anti-TNF therapy in itself. Is there an increased risk with combination therapy? It doesn't look like it, but I think we're underpowered to detect a real risk if there is there. I think we would have seen a signal if there was a big risk.
Would you recommend testing of all IBD patients before endoscopy or biologic infusions? Now, I should say, if I can just open this one, we are in London particularly testing or swabbing patients for all endoscopy at the moment, except for one or two isolated units. So not just for IBD. What do you think, Charlie? Do you think we should be swabbing all patients before they have any investigations?
This is a very, very challenging debate, I think. I think it's good that some people are doing it now, because we will get some information about whether or not it is worthwhile moving forwards. We know that at a community level, at a population level, that testing is vitally important. Is it critical prior to investigations or admission or other aspects? Do you know, I'm not convinced it is, but I think there may be some sense in doing it in your population intermittently. So, for example, if you bear in mind everyone's at a different sense, and if you want to know how risky your population is, if you test everyone when they come for their infusion over a period of 2 months and you have zero positivity, then that is reassuring. So genuinely, I don't think we should be putting blanket guidance on this for IBD patients, but I think it is something that people may want to consider at a local level.
Okay, so I've just seen this question. I think we should ask it, because there's a lot of conjecture in with some gastroenterologists about COVID and stool, and you did show feces and sewage. So you asked for this question, I think. What are your thoughts of COVID secretion in the stool, whether or not it's active, whether or not it's infective, and whether or not we should be testing for it?
Yeah. So there is virus in the stool. It's not obvious that fecal oral transmission is a critically important feature. There is SARS-CoV-2 in the stool. It's not obvious that it causes fecal oral transmission, although that does remain a possibility. So what does it mean? What's its significance? And, you know, how should we deal with this? And, you know, honestly, I think this has been vexing our endoscopy colleagues much more than it has us, because it is the thing that is limiting how endoscopy gets up and running again. It's just not clear that it's important. It seems much more likely, to my mind, that it is the aerosol infection via the face, mouth, and nose that is so relevant. But you know, I think all we can do is look at the literature that is present at the moment, and there are people better qualified than us to really answer these questions.
Okay, now you did, again, going back to the RAN panel and treatment during this period. Has this, in what way has COVID-19 changed your practice with biologics, if it has done?
So that's a great question. It has changed my practice. It's changed my practice to use biologics earlier so that we avoid steroids. So you might have a patient before in whom you'd have said, okay, we'll give a course of steroids and we'll see how you get on. And if you need another course, we'll start you on a biologic, for example. But in that situation, I'd rather avoid the steroids and just start the biologic. The question then is, what biologic or what class of biologic should you use? And broadly speaking, I've been guided by what feels like it makes sense. And this comes back to the lack of information about combination therapy and rapidity of onset, etc. So in terms of the combination question, our practice has been to use the drug that the patients have needed when they're sick. So if you've got a sick colytic, or you've got a patient with bad fistulizing disease, infliximab and azathioprine still seems like the right way to go, and I wouldn't have changed that because of COVID. But for many of the other patients, given that there has been that degree of uncertainty about combo therapy, we've been largely going with monotherapy agents. And that's meant quite a lot of ustekinumab and vedolizumab or adalimumab monotherapy, but often going away from anti-TNF therapy first line so that patients can be started on a monotherapy agent. Okay,
and there is a question here which I'm sure I could answer myself, but I'll let you have, about the use of vedolizumab, and I guess, the question's actually about acute severe UC, where we don't use it for onset and evidence reasons, but are there a group of moderately severe UC patients that are on the edge of admission that you would use something like that first line in this time?
Yes. So let's be clear about this. If patients are sick, if they're in hospital, we should use the drugs that we have the evidence base that they work for. And I think the recent gut paper from Peter Irving and colleagues very clearly illustrates that point. If you need steroids, give steroids. If you need infliximab, give infliximab. In the sort of outpatient setting, we've been using quite a lot of Vedo and ustekinumab and tofacitinib in those patients. And some of those have needed steroids as well, and we've then asked them to go and shield so that they're protected against getting COVID. But we've used, yes, Vedo, infliximab, Vedo, Usti, and tofacitinib in those groupings.
Another question. So with tofacitinib, with the potential increase in thromboembolic events, I should say potential, with higher doses, does that affect your choice of that drug at all during this time?
It may have done a little bit when there was a lot of COVID around, but now a bit less so. So I think our prescribing did drop a bit during the peak of things, particularly where we were waiting to see if there was any particular signal with any of the drugs. But having not seen any particular signal, and where we've been just trying to get people well quickly, then there's a lot of advantage to a drug that you can use without the need for steroids, and a drug that you can switch off very quickly as well. So if you did have a patient, for example, if you did have a patient on tofa who then got COVID, you can be confident that stopping the tofa its effect will wear off very, very quickly indeed, and therefore you would minimize whatever risk was associated with that drug.
Yeah, I think it's a very good point. So changing tack, because I think I missed these questions earlier. You mentioned telemedicine and our change in practice. I think one thing that maybe is different, because you and I work in the UK, is that we don't tend to think in medical legal terms about telemedicine to any great extent, but it's clearly a worry for some of our participants in the webinar. Are there first of all, number one, can you think of any legal issues with doing things by telemedicine and virtually? And number two, do you think that one requires particular forms of technology to do it well?
Yes and yes, I think is the answer to that. I think, if you follow good common sense and good medical practice with clear documentation and clear consent for whatever you're doing, you won't go far wrong. Is the short answer. So, you need to get at least verbal consent from a person. They consent to a video consultation, and you need to document your consultation in full, as you would do ordinarily. And I think if you do those things, that's more important. In terms of using the right technology, I think yes. I don't think it's right, although it was interesting in the survey that a number of people are doing it, necessarily just to pick up WhatsApp and video call your patient or use Zoom or FaceTime or whatever. The advantages of a proper hospital video consultation system is that your phone numbers are anonymized, all the security and everything else is put into place. Having said all of that, the phone is not without risk either. And actually, I think one has to be pragmatic about this. And one of the things that has always slightly put me off phone as a full replacement for a consultation is that you can't physically see whether a patient looks well or unwell or what their characteristic is like. And, I was very struck just last week in clinic when I was doing a near me video consultation clinic, and a patient who I could very easily have just had a phone consultation with previously, and via voice and via everything we talked about. And when we did a very detailed conversation about his Crohn's disease, it was clear that his Crohn's disease was in deep remission. But his physical appearance and the visual clues that we got painted a completely different picture. And this was someone who had been ravaged with stress and anxiety about COVID and many other issues, and was clearly struggling a lot. And so that would be something that I would have completely missed from a non-visual consultation. So that I think is important. And of course, we should ask about all of these different factors when we see patients, be it face-to-face or phone or video. The examination side of things is curious. In the US, where they have to do a full video consultation to get reimbursement, that also includes some form of virtual physical examination. And there are checklists that you can follow to go through that, and with the appropriate consent, I'm led to believe by some US proponents that you can go as far as performing at least visual inspections of perianal Crohn's disease, for example, in very selected examples where you might otherwise not be able to assist at all. So everything is possible with appropriate forethought, technology, documentation, and consent.
Thank you. That last example sounds like a particularly challenging one.
I would not recommend it. No.
Perianal Crohn's disease virtually.
Yeah.
There are a couple of questions which actually are covered, and for those of you watching at the moment, some of the literature on the slides is exactly where you should go to get really thorough answers to these questions, but Charlie can answer them very quickly for you now. Patients with IBD on immunosuppressives who then become infected with COVID-19, which medications would you stop? And I know this is covered on the slides, but maybe you could summarize, Charlie.
Sorry, Charlie, just repeat the pertinent part of that again.
So you have covered this earlier, but in patients with IBD already on immunosuppressive drugs, so either biologics or immune modulators, who then get COVID-19, which drugs would you stop?
So whilst they have COVID-19, I would stop pretty much all IBD medications. That keeps things pretty simple, and then restart. A couple of weeks after someone's finished their symptoms. Okay,
that's great. And a similar question, but at the other end, if you like. So in a patient with COVID-19 in whom you suspect IBD that may need treatment, do you change your investigation during this time? And I think this is more, I'll ask this question in the context of, for example, where maybe somewhere like Brazil is now and London was a few weeks ago, where you have sparse availability of investigations. How would you change your investigation of those patients?
So I think that the very simple answer is that we have all had to make quite challenging clinical decisions in IBD patients with limited information. And so I think the most important thing to do is to try to direct difficult IBD decisions to people who are most able to deal with those questions and those decisions. So for us, it's been having a consultant-led service so that our experienced IBD nurses can have a direct communication channel so that we can deal with that. Because you're dealing with often patients who are just phoned into the helpline with symptoms. How do we get their bloods done? It can be as simple as that. Where's the patient going to go? Is the patient got the fear to even go to the GP or to the hospital to get their bloods done? What's going to happen with that? Otherwise, what about, let alone getting calprotectin and scopes and all the rest of it done? So I think wherever you are in the world, that would be my biggest take home, would be don't defer the decision making to junior people, for example. Do that at a senior level. But where there is necessity to get investigations done, I think it's important to get done, particularly imaging, probably, because that's the most potentially risky thing, especially in Crohn's disease, if you miss someone who's got penetrating complication.
So we're coming to a close now. Unbelievably, it's been nearly an hour.
Flies by.
Charlie, I always sort of do this to you. I'm going to ask you a more global question, or philosophical question, if you like.
Good.
Given the COVID-19, what has happened to all of us, what is the main thing in your clinical life that you think will change? If you were to pick one thing that would change.
I mean, very clearly, very, very viscerally, I think the thing that I already miss, the thing that's different, is the clinic. And some of those things will be for the good, and some of those things are for less good. I mean, it's very clear that we had an unsustainable clinic before. The compounding prevalence of IBD, the more and more patients, the waiting rooms were getting more and more packed. And whilst I would enjoy our big IBD clinics because it was us doing what we wanted to do and it was seeing lots of people that needed to be seen, actually, I don't think the experience was necessarily that good for patients. who had to drive to the hospital and park and wait, and they'd often get seen by any one of the team that's there. And actually, what we're doing now, although the clinic will clearly change, there is no way we can go back to packed waiting rooms, even 50%. We're probably down at 20 to 30% of what we had before. And so that plus consulting via phone and video and implementing technology with patient apps and other systems, that's something I think we can really look forward to and embrace as a community moving forward. Because if you think, God, I miss the clinic as it was, yes, we all do. We'll still have the space to see the face-to-face patients, but we need to work out how we see the right patients at the right time so that we can make the biggest difference. And actually, there's a further point, if you'll grant me the luxury, which is that I think we, from a research perspective as well, because this really ties into this, we need to think about how we can truly address the real unmet need in IBD patients. I think we need to focus as a global community on the core questions that are important, that are going to make the biggest difference to patients' lives. And right at the forefront of that is improving standards of care across the piece. And then behind that, it's research and infrastructural developments that we can use to make patients' lives with IBD better. And I think that focus, that conversation needs to happen in earnest now, so that we can use what will be lesser resources in a more challenging environment, in economies that are broke, to make sure that we care for our patients better.
Thank you so much, Charlie. I knew you'd get 2 points in instead of 1, but that was perfect. So a huge thanks to Professor Charlie Lees for yet another excellent webinar and some superb questions. Thank you so much for your for becoming so involved in the webinar today. A few things from UEG. I think you'll see Ruby has been writing. Please do join with the My UEG account, which is free. You can do it online. It's come up on the slides now. Second thing to mention is that we do have our next webinar on the 15th of July, which is looking forward to a life after COVID or during COVID in the recovery phase, coming up with Heinz Hammer and Giovanni Barbara. And the third and final thing it really is to thank all of you for joining and to wish you well this evening and in the coming weeks and months. Many thanks for your participation this evening.